First of all, I'd like to thank Dr. Unnikrishnan sir and his team for the excellent program made so far. It is a joy to be a part of this academic venture. And once more, thank you to all the teachers and my crowd. So coming to the case, we had a lot of diabetic patients in our population. So this is conflict because we have discussing with a non-diabetic person and that too spontaneous or unprovoked hypoglycemia. So we all know that bear is the most enjoying for the honey. So similarly, the people become so hungry that they just want to have something and munch. So as you see, the Swiss the Alps has been depicted in Toblerone. So we have got a varied symptoms of non-diabetic patients who are present with hypoglycemia. These include sympathoadrenal symptoms like headache, dizziness, blurring of vision, hunger, and they are also having neuroglycopenic symptoms. The sympathetic system means they either fight or flight, so they are very upset. The other side, they just rest and digest, so they don't have much energy left. So the Edinburgh classification is the one which has comprehensively and scientifically analyzed these symptoms and classified wonderfully into these 11 symptoms, classical, and we have to recognize these symptoms in each patient. The Indian study in diabetic population was made in Chennai, and this study showed that dizziness is one of the prominent symptoms. Next coming is sweating. These are all subjective and varies between individuals, so we have to come across the correct spectrum. So I heard there is no voting pad, but this is a good chance for you to understand what is the accelerated cutoff for symptomatic hypoglycemia. The various guidelines are coming, and they are all basically for diabetic adults. So non-diabetic adults, the classification proposed will be, the answer would be answer 4, which is 55. So this is according to the JCEM, which is the endocrine classification, beautifully described in 2009 by Cryer et al., who have described that healthy non-diabetic adults develop symptoms at a threshold of less than 55. Recurrent hypoglycemias will make the patient having this cutoff to respond lower also. So when we come to endocrine aspect of hypoglycemia, this scientist we have to remember, which is called Alan O. Whipple from the Mayo Clinic, who has beautifully described the symptoms associated with hypoglycemia and the triad which we have to recognize. We have to document the sugar, we have to identify that it is hypoglycemic, then we should give simple sugars to correct it. So verification and documentation along with the classic treatment. So Harrison textbook makes a good table, but it is difficult to understand, but I will just simplify to you in this presentation. And this first will be to identify whether it is diabetic or not. Further on, document the Whipple's triad by subjecting the patient to a fasting protocol. If we cannot demonstrate, then we have to measure biochemically. Later on, only we should image. This is the classical teaching. The common causes of hypoglycemia in outpatient setting, according to European Journal of Endocrinology 2012, mentions is that the initial one is to be factitious hypoglycemia. That is the first thing in mind. Later on, the endogenous hyperinsulinemia conditions come into place. The reactive or post-absorptive phases also come there, walking to you. The prescribing error of some drugs and organ deficiencies or organ failure are all the rare possibilities. The inpatient settings, we always consider a drug-induced hypoglycemia. Some antibiotics are known to cause that. Prescribing error again. Critical illnesses or sepsis. We never evaluate when the patient is under sepsis or under stress. Then again, the hormone deficiencies. The counter-regulatory mechanism is the one which has been described traditionally. The biochemical pathways for the fed patient and the unfed patient vary. So the food from the load from the glucose comes up to 6 hours. Later on, as the other pathways take over, the hormones also come to play. The initial player is insulin, that is coming at around 80 to 82. Later on, as the cutoff becomes lower to 70, it becomes glucagon, adrenaline, growth hormone. These three come into action. These are all trial-based. There is no definitive in the textbooks. The cortisol release is the one which we have to consider because neuroglycopenic symptoms and autonomic function dysfunction happens only after the cutoff of 45 to 50. We never allow the patient to go below that. If at all we have a patient unprovoked seizure, it is the one possible. The case which I am coming, I have 3 cases. The first one being a 27-year-old young female coming with recurrent episodes of panic. She had profuse sweating, palpitation and dizziness. Being an IT professional, she wanted to go around, but unfortunately, she's staying in station because she's unable to move because of the tensions and associated with the hypoglycemic events. But she has actually not documented anything. Prior to this coming visit, she had a value of 56. That was more often in the fed state. It was a severe episode, and she tells that she had to go to the hospital for IV fluids. So when she presented to me, I had to just choose among these 4 options. So the initial one would be whether you open an emergency tray and give a steroid, which is a life-saving drug, whether you just document the RBS and start an IV fluid, and whether you to just admit the patient for a fasting. This is a diagnostic dilemma, depends on the clinical situation you are working with, and ideally you should never image initially. So the answer would be to admit after evaluating the patient whether it is having any illness. The fasting hypoglycemia after 5 hours after a meal has been described by a Korean group as 2 situations, unwell patient or a well patient. The unwell patient we have always considered organ failure, hormonal failure, non-islet cell tumors, glycogen storage disorders, and rare metabolic disorders. A well patient who's coming to you like this patient, we should consider endogenous hyperinsulinemic hypoglycemia. The common causes of which the prototype is insulinoma, the next being insulin receptor antibodies and non-insulinoma pancreatitis syndrome, which I will describe. Dr. Unnikrishnan sir was the author of this one good editorial journal. It came in 2009. It was regarding a study where hypoglycemic side of hypothyroidism was explored. The role of non-diabetic patient also was studied as autonomic causes. The one which we have already not touched in this presentation would be Addison disease. JF Kennedy was the one who had a lot of symptoms but unrecognized. The fatigue was progressive, and the late stages he had a lot of symptoms of these. So coming to the protocol, that is 72-hour fasting test, it's a challenge in itself because we are provoking the patient, a healthy patient. We want to recreate a circumstance and we have to get a hypoglycemic event. The gold standard, because it has been foolproof, it has around 90 years of proof. The protocol being, we start the fast after completion of an evening meal. If we have a documentation that the patient had an early onset, then we begin after only a light breakfast. We discontinue all the non-essential medications. The drugs, I will just touch into that. We allow only water, black coffee or tea. We advise the patient to be active. We always document meticulously. We send the urine for ketones 6 hourly and also the glucometer value. The threshold in this is 60 because we know that lab values and glucometer value have a disparity. So once it is less than 60, we check more frequently. In an institute where I worked, Amrita, we had a protocol where we used to check half an hourly. But depends on the situation, we can check more frequently. And once the glucometer value is less than 50, we send for a lab RBS. Simultaneously, that time only, we keep aside critical samples. Critical samples are ones which are important for the counter-regulatory hormones. These include insulin, C-peptide, another branch molecule, cortisol, and growth hormone. These are easily measured by a standard lab, reliable lab. If the lab is confirmatory that the value which we already sent comes to less than 55, we send the critical sample and the patient is allowed to take food. Make sure that we have a threshold of suspicion of OHA screening. We have a population who has parents having diabetes. We don't know whether the child has surreptitious exposure was there. Always, if it is there, we can use a serum level of beta-hydroxybutyrate also. An extra tube can be kept in situation where we want suspecting autoantibodies and IGF-1 level also. Because the chain of insulin, we have seen that insulin is formed by alpha-beta chain, C-peptide is separately cleaved. So we understand that we can estimate the level of hypoglycemia by estimating C-peptide levels. This journal study was published of 70-year study in Mayo Clinic, which essentially told that with test of time, hypoglycemia will essentially develop in all insulinoma cases, 75% within 24 hours and up to 90% by, there are still 10% patients who still survive that period. So that is why we should always see whether beta-hydroxybutyrate concentration is also positive. This is the guideline-based chart which shows that 55 level is the one we use the threshold, and C-peptide level normally is less than 0.2. Once it is more than 0.2 or equal to that, and insulin level is more than or equal to 3 MIU per liter ml, we suspect insulinomas. The quantum of rise of insulin is more in autoantibody syndromes. So that is another distinguishing point. And the level of beta hydroxybutyrate is also important because it is normally positive in fasting patients, whereas it is less in case of insulinoma and other conditions. The circulating oral hypoglycemic agents are also measured in blood, antibody to the blood. So this is a case which we had already discussed. She underwent supervised fasting, developed symptoms at 45. Insulin levels correspondingly drawn was 28, and C-peptide level is 3.4. So we had the imaging done, after which we proved that the patient had a lesion of pancreas. We subjected the patient to a laparoscopic surgery, and this is the robot-assisted surgery done in Amrita. I'm thankful to Dr. Sudhir for sharing these images. This shows the harmonic entering the abdomen and puncturing the lesion correctly identified. Then we are enucleating that test. Removal of the tumor is also important. In cases where we cannot remove the tumor, we go further and we ask to try for a resection of the tail of the pancreas. Ultimately, the patient had to have a resection of the tail of the pancreas. So this is actually curative also, because the treatment is also there by doing the surgery. So diagnosis, as per consensus, I have already mentioned. Additionally, they have mentioned that insulin to C-peptide ratio, equimolar ratio, is less than 1. And also pro-insulin ratio, but pro-insulin is not done in most of the labs. If it is more than 5 picomole, it's again useful. The clinical characteristic of insulinoma, they are 4 per 1 million patient years. They're usually solitary, they are well encapsulated benign lesions and having a threshold of 90%. And medical management is usually by asking them to advocate diet, waiting for 15 minutes, taking the blood. But when you have time for surgery, when we don't know whether the treatment is okay, we can use medical management options are constant infusion with glucose, diazoxide, somatostatin analogs, glucocorticoids. Imaging localization, the best one is endoscopic ultrasound image. MDCT, MRI pancreas also have a good sensitivity. The recent advocated ones are the gallium PET and the daughter. Insulinoma have been hidden and diagnosed by extending study. It's a GLP-1 tagged study in Western literature. Intraarterial calcium stimulation test is a useful test in Western. It is actually done in Mayo series, not usually done because it's very interventional method. Surgical management, mostly benign. Head region may require a pancreatidotomy. The tail region requires distal pancreatic resection. We should not attempt blind resection until we are sure. Malignant insulinomas, part of Men's syndrome or neuroendocrine tumors, require aggressive pancreatic surgery, including vascular resection. This is the 10-year unpublished data, and I'm thankful to Dr. Ashwin to having helped me with the medical records. 9 patients, out of which 3 had been during Dr. Unni's period. The age group was young, less than 50 in most of the patients, except one. And the presenting symptoms were neuroglycomic symptoms. One had a lot of seizures as well. And 2 people had actually died under the follow-up period. It's actually depending on the histopathology features and the level at which the localization is done. The larger study was done in CMC Vellore showed that there is a lot of role for histopathological diagnosis. And in those patients, 100% of them had neuroglycopenic symptoms. The non-insulinoma study, because we don't identify by fasting test, we don't identify by any imaging. Sometimes we do a CT of the chest or the thorax, we can identify IGF-2 secreting tumors. In some other conditions, 18F dopa can be also helpful. The second case, being a fatigue, 66-year-old male who was staying alone, non-diabetic with 1 month of fatigue. Early morning he used to just doze off, and later on he used better after taking food. Past history, there was not significant except for a history of taking Ayurvedic medications and history of central serous retinopathy. Actually, the executive checkup was done, which was unremarkable, and he went home without a diagnosis. So again, this is the things we identify. So we should know that there are a lot of herbs in the population we have exposed to that have got glucose lowering potential. These are the guidelines from RSSDI which describe that there are many Chinese elements as well as the herbal things which have to be, even green tea, ginger, all these are included in this list. So naturopathy was tried, so we were not sure whether he had some issues like that. We suggested him to take frequent meals, regular monitoring, no one to admit, so he had to just come back. And later on he was brought unresponsive with a glucose level of 40. Endocrine devaluation, actually he did not require a 72-hour fasting. He developed symptoms by 46 at 2 hours only. The cortisol level was okay and other levels were normal, thyroid was normal. So C-peptide level and all the screen was sent. And this case was an autoantibody syndrome which was positive. In our lab, we used radioligand binding assay. ELISA test is not useful for anti-nuclear anti-insulin antibodies levels. See, the insulin level is more than 300. That shows that it is so much levels are there in the blood. CT abdomen was done, unremarkable. No other lesions were identified. So the recurrence of CSR is high with steroid. But we know that autoantibody syndrome, we need to give steroid. So again, we asked ophthalmologists to opine and they just told us to go ahead. So a small dose was given, but no relief, white fluctuations occurred. The action plan, we saw that after 1 month, steroid-induced CSR recurred. This patient was requiring plasmapheresis of 6 cycles, after which the patient became totally asymptomatic. So this is called Hirata disease. Last 50 years, around 45 years, we have got so many cases described, more often in the Japanese literature, antibody direct against insulin or receptor. There is direct stimulation of insulin secretion. And offending drugs can also be there, like sulfhydryl containing. We can see that the same antibodies involved in the type 1, like GAD, we have seen, but you can see IAA, which is a good level. Why this is causing hypoglycemia, not diabetes, is because there is sequestration of the insulin initially, later on they release suddenly like a reservoir mechanism. This is how we can understand. The drugs like alpha lipoic acid, thionamides are involved along with some autoimmune conditions. We have also seen hepatitis C being a good condition which can predispose. Mechanisms would be sequestration insulin initially. Once the levels build up, they release together and hence stimulation of pancreas. 60% cases spontaneously resolve, and some cases definitely require steroids, and some cases will mean requiring, 20% will require immunosuppressants. How to distinguish? We have to again measure the insulin levels in a reliable manner and autoimmune markers to be tested. And we can see that insulin to C-peptide ratio, a big study from St. John's was done. This showed that the insulin C-peptide molar ratio of less than 1 is a good sensitivity index. If it's less than 1, definitely it cannot be insulinoma. It is insulinoma. If it is more than 1, definitely there is a high insulin level. It should be autoantibody syndrome. Methimazole is the most commonly implicated drug. Other drugs include glutathione and interferon alpha, penicillins. This is a study from Amrita published by Dr. Praveen et al. This described, it came in ADA, that is the American Diabetic Institute guideline. We had 8 patients. So the same limit, 10 years, we had 9 patients with insulinoma and we had only 8, we had equal number, that is not rare enough in our population. We had seen that ALA, that is alpha lipoic acid, was identified in one case, carbamazole in another case, and we have seen the good improvement with steroids in all of the cases, and some patients had spontaneous recovery. The biggest study published in Chinese journal was having 73 cases. Again, the most commonly implicated drugs in methimazole and these. So we should always have a suspicion of drug-induced hypoglycemia when these drugs are in the list. The classical drugs being gliflozin, quinine, pentamidine, indomethacin, and levofloxacin, again in the low quality. Some cases, glucagon can also cause. Some endoscopy people use glucagon for getting the patient better. So this is not to be used because again, it can't stimulate, it can also cause a detrimental value. Beta blockers are classically described can mask the autoimmune, autonomic symptoms. Fatal hypoglycemia has been reported by Dr. Jubin et al. And alpha lipoic acid was actually a drug used in diabetic population. Again, we should think about that. The case 3, if it is late, can I just rush through my slides?
Rush.
Yeah. So this was a patient recently described. He just told he is very tired. Actually, he is a staff nurse in Oman and intense hypoglycemic symptoms during the noon time. Once it was more than 3 minutes for recovery, he required all the tests. As usual, he was in a hurry, so another doctor had done an MRI pancreas, which was unremarkable. He came requesting for a good workup. So again, response, we usually try for this is actually a case of reactive hypoglycemia because he had symptoms when he was having food. I think one response. So, okay. Yeah. So response is actually, the answer is B. We should always subject the patient to a mixed meal test with a high carbohydrate content. The classical teaching is that OGTT is a fallacy. We should never use that as a test for 5-hour test also because there is a normal glucose metabolism also can produce this. And we usually, in our center, we use a mixed meal clinic. In Ludhiana, they have got described that Ensure powder given in this proportion for 240 ml and 40 grams can also have a good results in the values. So this case, just again the same thing, unwell patient, galactosemia, a rare condition like acute food poisoning, reactive hypoglycemia in the case other cases. Because we just described akki fruit, I should not be forgetting that there was a lychee fruit episode in India, in Muzaffarpur in Bihar. It was a mystery disease. There are a lot of children dying, and there was hypoglycemic encephalopathy. The study actually is published in Lancet, definitely proved that unripe lychee contains toxin. So I will just finish in 2 minutes. How to logically and stepwise approach, published in the Endocrine News in a very simple manner. The first step, is there any alternate explanation? The first, we had seen a patient with a panicky episode. She can well be a patient of a pheochromocytoma. So always, whether it's an alternative explanation are there. Second, whether it meets the Whipple triad. Third, have you rolled out the drugs? The fourth, whether it is in a fed or the fasting state. Whether the patient is unwell, unstable, whether it is sick. So always consider all these illness which can itself cause hypoglycemia. And correct the adrenal insufficiency, pituitary insufficiency before you contemplate other things. Diagnostic testing is by the flow chart described in 72-hour glucose or the mixed meal test. Imaging and localization should only be in the towards the end of this thing. So we have exposed to ambulatory glucose profile. Just one slide on that because we are using it in a clinical practice. It is useful for mostly in diabetic population only because in a study in St. John's published, it's only giving fluctuation. It doesn't give any conclusion. So take-home message will be, there is an excellent survival rate and quality of life improvement by using therapeutic intervention for benign insulinomas and insulin antibody syndrome. So judicious imaging, always remember that drugs and toxins can itself be a cause. And thank you for the great listening.
Thank you very much. Due to shortage of time, we might permit only 1 or 2 questions, if any.
There is no description as such. They have actually told that it can be a correlation. There is no reaction like such.
Thank you very much. Thank you, Mohan.